Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Judy King. I'm a consultant medical oncologist at the Royal Free and Barnet Hospitals in London in the UK. Welcome to this Medscape programme, which is titled Latest Advances in Breast Cancer Care, Highlights from Chicago 2024. I'm also joined by Paolo Tarantino, an Advanced Research Fellow at Dana-Farber Cancer Institute and Harvard Medical School in Boston in the United States. So welcome, Paolo.
Hello, Judy. Hello, everyone.
So in this Medscape quickfire, we'll have sort of 30 to 90 seconds to answer each other's questions. So it's going to be quite quick fire. And throughout the exercise, Paolo and I will be reviewing the latest data on breast cancer care, which came out of the most recent clinical oncology meeting in Chicago, ASCO 2024. So Paolo, let's get started. So in your opinion, what would you say were the most important topics which were addressed at the meeting? Let's say 3 or 4 top picks.
So I think there were a lot of interesting presentations at ASCO, but 4 topics really stood out, in my opinion. And one of them was the expansion in the targetability of HER2 as an oncogene and as a protein. We've been thinking for decades about HER2 positive as targetable, and then this moved to HER2 low, and now we saw this new entity of HER2 ultra low also emerging. And then we have CDK4/6 inhibitors beyond progression, the first phase 3 trial in this setting, very intriguing. Adjuvant immunotherapy, which has discordant data, and we saw some positive, interesting data at ASCO, and finally new ADCs, which are my passion, and I guess we're going to talk about them today.
Great, so thank you for that overview. So let's talk about HER2 expression and this ultra-low element and what the implications will be.
So absolutely. As I was mentioning, HER2 positive breast cancer is a clearly targetable entity with many drugs targeting it, but we realized recently that potent novel anti-HER2 ADCs can also lead to improved overall survival in patients with HER2 low breast cancer, IHC1 plus or 2 plus non-amplified. But even within the HER2 zero space, where we thought there would not be any tumor cell expressing HER2, actually up to 10% of cells can still have some weak HER2 expression, as confusing as it can be. And I really think we need to move beyond the current IHC categories, but with what we have right now, even within the HER2 IHC 0, we can dissect 2 populations of patients, HER2 ultra low with some minimal HER2 expression, which we learned that can benefit from anti-HER2 antibody drug conjugates, and HER2 null that we still don't know, but may potentially also benefit from anti-HER2 conjugates.
Yeah, so very confusing. So ultra low and 0, new things to be thinking about. So let's just sort of run through the data post ASCO, and if you can maybe run us through DB06, because that was the big study this year.
So yeah, it clearly was a highlight and strongly linked to this ultra-low definition, because this was a phase 3 trial kind of similar to DESTINY-Breast04, randomizing patients with hormone receptor positive metastatic breast cancer with HER2 low or ultra-low breast cancer. Almost 90% of patients with this disease have received 2 prior lines of endocrine treatment, but no chemotherapy, so chemo-naive, and randomizing them to T-DXd or chemotherapy, either capecitabine or paclitaxel or nab-paclitaxel. And the primary endpoint in this trial was progression-free survival in the HER2 low cohort. And what we saw basically is a meaningful improvement in progression-free survival and a statistically significant improvement from 8.1 months with chemo to 13.2 months with T-DXd for an hazard ratio of 0.62, statistically significant. And this was very similar in the HER2 low population primary endpoint, in the ITT, which includes also 150 patients with HER2 ultra-low disease. And also, if you only look at the patients with ultra-low disease, same positive outcomes. In terms of side effects, With TDXD, we saw basically what we have seen in other trials, meaning that nausea, fatigue, and mostly chemo-related side effects are the main toxicities, although we still see approximately 11% interstitial lung disease rate of any grade, and there were also 3 cases of grade 5, which reminds us of how important it is to monitor for ILD in population of patients receiving TDXD. I personally felt that these data were very intriguing. I would love to hear your opinion about it. What is your clinical takeaway, Judy, about the impact of DB06 in the treatment of patients with HR positive, HER2 negative, HER2 low, ultra low metastatic breast cancer?
I think the interpretation was really interesting, and there was a very good discussion by Ian Kropp, and he really picked out these 3 questions that I think we should address, which were what line of therapy should we use TDXD, which patients, and what about the testing? So in terms of what line of therapy, we've just heard about the toxicity. We know TDXD is not that easy a drug, and there's that ILD risk. So there's a good argument for a lot of patients for giving them first-line capecitabine or taxanes. And we've seen people on that for a very long time. And then we know they can have TDXD on progression. However, one of the things that was really brought out in the discussion was the overall response rate. So you get a really much deeper response rate with TDXD. So in terms of what line of therapy should we use TDXD, I think it is, well, partly patient and clinician choice, but those patients with very symptomatic disease where you really want that response rate, that might be the kind of patients that you'd be thinking about TDXD in this sort of DB06 first line versus second line, and maybe lower volume in the second line. So which patients in terms of this HER2 low versus ultra low? I think we're very comfortable now with the HER2 low definition, but the ultra low, the question is how confident are we in this? Even though it was quite a small group, only about 17% of patients in the study, it did very much look like the ultra low group responded very much the same way as the HER2 low group. So I think that people will be confident to use that definition. Having said that, I'm not sure how our histopathologists are going to feel about going back and having to look at slides again. And this really does bring us back to the final question. Are we confident in the way that we're testing for these patients? You know, we all know that the IHC score was set up to test for HER2 positive, to really identify the 3 pluses. And when we get to the point where we're looking for sort of 0 to 9% staining, this is not what the test was set up to do. And I think we are going to be needing to look at different ways of measuring this in the future.
Well, Judy, I think we could talk about this topic all day long, but there were other presentations that also I think may have impacted practice presented during ASCO. And one I would like to ask you about is the PostMonarch phase 3 trial. You know, we've seen in recent years several phase 2 trials of CDK4/6 inhibitors beyond progression. And now for the first time, we see a phase 3 trial, and there's been a lot of debate surrounding the results. Could you please guide us through what this trial showed and what may be the implications of PostMonarch in clinical practice?
So I think this was really important because all of us have patients on first line AI plus whichever CDK4/6. And the question is what to do on second line on progression. And so we've got data with the PIK3 kinase. If you have a mutation there, then we've got the inhibitors. And if you've got an ESR1 mutation, then we've got the oral SERD data. But what about all those patients that don't have a mutation to sort of guide you in that next line? And there have been lots of questions asked in the past about should we continue the CDK4/6? And so that was really the basis of this study. So these were patients who'd progressed on their first line, CDK4/6 plus AI, and they were randomized to either fulvestrant, we could argue about whether that's the right comparator, versus fulvestrant and abemaciclib. So the initial analysis showed a hazard ratio of 0.73, which was statistically significant, but in terms of absolute benefit, it wasn't a very long clinical benefit for continuing the abemaciclib. But then when the data was cut a second time by the blinded independent review, the hazard ratio was much better with 0.55 and a much more sort of clinically relevant improvement in progression-free survival. So there's a couple of things here. Firstly, you wonder a little bit about whether there's been quite a lot of censoring of data. And then number two, this is mainly a CDK switch study. So we've seen previous studies with palbociclib where there has been a continuation which have been negative. But in 2 studies now, we've had mainly palbociclib patients who have switched to, in this case, abemaciclib, and in a previous phase 2 study with ribociclib. So I think that the answer is probably the switch strategy does look like it has legs.
So I really think having more option always helps. And in this case, that there was a statistical benefit. It can be argued, of course, if it was clinically meaningful, but still I feel that it allows us to tailor treatment for our patients. So going back to the key topic list, there is one important one that is immunotherapy, and in particular immunotherapy of triple negative breast cancer that is in the list. Could you tell us why? What was the the most important presentation in terms of immunotherapy of triple negative breast cancer at ASCO 2024?
Yeah, so I was really excited to see the A-BRAVE study presented. This is an academic study run by colleagues in Italy that we put patients into. I think this was really thought-provoking because we've had lots of data, not just in breast cancer, but in lots of other tumors, showing that neoadjuvant immunotherapy is really important. And having the cancer antigen in situ is much better than having surgery and then giving immunotherapy adjuvantly. So this is the A-BRAVE study where patients, there were actually two groups. The majority, over 80%, had neoadjuvant chemotherapy. And then if they had a non-path CR, so those high-risk patients, then they get a year of avelumab versus observation. There were a small proportion of patients who were your standard post-op adjuvant patients, but that was not the majority. The data was a little bit tricky because the primary endpoint was DFS, and this was not achieved. However, the secondary endpoint of overall survival did show a significant improvement with avelumab. And so probably what we're seeing is it's a little bit tricky, and I think there's a little bit more head scratching needs to go on. But does that mean that those neoadjuvant patients who had a non-path CR, we're selecting those high-risk patients and identifying the ones who are more likely to benefit from immunotherapy in the adjuvant setting, and therefore can we potentially avoid giving everybody immunotherapy up front? So I thought the A-BRAVE study was really interesting, and that was my key trial. But there were other studies looking at immunotherapy in early breast cancer. And we saw the I-SPY 2.2, which I found actually fascinating. I thought that was great data. So Paolo, do you want to summarize that data and their implications for us?
So absolutely. And I think this is a very exciting field for two reasons. First of all, because we have seen that ADCs lead to increased activity compared to traditional chemotherapy. And we've seen that the combination of ADCs and immunotherapy work pretty well. For instance, if you take the data of first-line datopotamab deruxtecan plus durvalumab in the Begonia trial for triple-negative breast cancer, more than 70% response rate, PFS of more than 1 year, which is really unprecedented in triple-negative breast cancer, and boded well for taking this combination in the early stage setting. And so what the I-SPY 2.2 investigators have done is testing 4 cycles of Dato-DXd with or without durvalumab, and we saw both the monotherapy and the combination data at ASCO. And if we focus on the combination, what we see is that for 4 cycles of these 2 drugs achieved more than 40% path-CR rate in patients with triple-negative early breast cancer and approximately 20% in patients with hormone receptor positive disease. But I think what was very interesting also in this cohort of about 100 patients is that in the immune positive cohort, that was nearly half of the population, you had up to 65% pathologic complete response rate, and this combination met the graduation threshold in ASPY 2.2. And so we'll see more about this combination. And there is also a phase 3 trial looking at Dato-DXd plus durvalumab in the TROPION-Breast04 trial for triple-negative breast cancer. And we do hope that we'll be able to leverage the potential of ADCs, not only for patients with metastatic disease, but also for patients with early stage disease in the future.
So, Paolo, I agree. I think the Dato-DXd combination with immunotherapy is going to be really interesting. And I think the I-SPY 2.2 platforms, we're going to hear a lot more from them as well. So let's come back to the ADCs, actually, because there were a number of other new ADCs at ASCO 2024. What stood out for you?
So yeah, ADCs are modular agents, and so slight changes in one of the parts, the antibody payload or linker, can really change the clinical profile of the ADC. And we're seeing many of these changes leading to novel ADCs tested in the clinic. We actually saw a phase 3 trial at ASCO of a novel TROP2 targeted ADC, sacituzumab tirumotecan, that is somewhat similar to sacituzumab govitecan, but the payload is also a little different, and we know that this can have an impact. So the trial OptiTROP Breast01 was a phase 3 trial for patients with pretreated triple-negative metastatic breast cancer, and basically what we saw is that the ADC led to a major improvement in progression-free survival compared to physician choice of chemotherapy, 6.7 months of median PFS versus 2.5 months with chemo, and also a significant improvement in overall survival. And we also saw a Nectin-4 ADC that is already established for patients with bladder cancer tested in breast cancer. And for enfortumab vedotin, what we saw is approximately 20% response rate in patients with metastatic or more receptor positive or triple negative breast cancer, which I think is intriguing but not yet practice changing in any form. But what I hope is that we can identify a biomarker to enrich for responses. And recently, Nectin-4 amplifications have been suggested to enrich for responders. So I really look forward for the biomarker analysis of this trial, and in general to see new data with new ADCs, because I think this field will keep on moving forward in the next few years.
I agree. I think there's going to be a lot of finessing of the toxicity of the payload versus the targets, and we're going to have some fun and games trying to figure out what we do with the sequencing, but these are questions for another day. I think we are out of time, so thank you, Paolo. It's been a great discussion and lots of fun, so thank you for joining me today.
Thank you, Judy. Bye.
And thank you to all the viewers for participating in this activity.